Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk.
I'm Joff Lacey, and I'm here with a very well-qualified guest to discuss the recently published NAP6 project. Tim Cook, Professor of Anaesthesia and Intensive Care Medicine at Royal United Hospital, Bath, and Director of the National Audit Project, or NAP Project, as we all know them, which has been an enormously successful series of projects casting light on major aspects of anaesthetic practice. So, Tim, thanks for coming along.
It's a pleasure, Joff.
First of all, congratulations. Huge success with NAP6, the largest prospective study of surgical and anaesthesia-related anaphylaxis. 3 million anaesthetics analysed over the course of a year, 100% of NHS trusts involved. And a logistical headache, it sounds like. So before we get into the highlights and the main findings of the project, can you just tell us a little bit more about NAP and how you got involved and the logistics involved in coordinating such an enormous project?
Well, I've been involved for about 12, 13 years. This is my last NAP. I'll be moving on. They emerged really from planning almost on the back of a fag packet for NAP3. NAP1 and NAP2 were very much inward-looking projects, looking at how anaesthetic departments worked. And there was a dramatic change brought about really by Tony Wildsmith with NAP3, and we started looking at the epidemiology of rare events.
Yeah. And
since then, the projects have looked at events which are important to patients, important to anaesthetists, too rare to study with other types of projects, so not suitable for RCTs or straightforward longitudinal studies, but also complications which are significant and inadequately understood. And the original aim was that we provided better information for patients.
Yeah.
So, for instance, with NAP3, the aim was that we got better information on the frequency of life-changing complications from central and axial block.
Yeah.
And so the aim was to look at numbers. And they've been, almost to my surprise, a great success. And I think they're a huge credit to Anaesthesia UK, to every anaesthetist, and probably every anaesthetist in the UK has taken part in the NAPs in some respect.
Why are you surprised by their success?
Because although, I won't pretend there wasn't a lot of effort to set up the early NAPs, we keep on going out to the anaesthetic community and asking people in individual hospitals who are increasingly busy to provide us with information, and it's often information both about what they do on a regular basis with a large number of patients for surveys, but also providing information on cases where a significant complication has happened, particularly with NAP345, things that may have had a massive impact on not only the patients they care for, but also for the anaesthetist personally and professionally. And I think that the fact that anaesthetists have been willing to, time and again, very honestly and openly present their cases to us, from which we learn as a profession, is a huge credit to those individuals and to the professionals in the broader context. And I think, although there's lots of focus on the numbers that come out of NAPs, I've always felt that the themes that emerge, so if you, at their simplest, they're a collection of case reports.
Yeah.
So we've got 84 case reports from major complications from axial block. In NAP3, we've got 180 complications of airway management and life-changing complications. In NAP4, we've got 150 cases of awareness. In NAP5, and in NAP6, we've got about 300 cases of life-threatening anaphylaxis. So at their simplest and their worst, they're a collection of case reports. But when we put those large numbers together, we're able to extract themes. And the review process, so the projects take about 4 years now. There's a year of planning, a year of in-committee preparation and surveying, then a year of data collection, and then a year or a year and a half of analysis.
I had no idea it was that long. That's incredible, yeah.
So it's a little bit over 4 years from probably 5 years since NAP6 was chosen as a topic, since the topic of anaphylaxis was chosen for NAP6. And I suppose
if you agree, that part of the enthusiasm of the anaesthetic community in ensuring that this data is collected is because they are topics, they are questions that everyone wants to know about. It's for the anaesthetists who know, well, I can't really give that information to my patient, so I don't really know about that, and therefore that's why I'm willing. So it's the selection of the topics that are as important as anything, really.
Yep, and we're in the process of deciding what NAP 7 will be.
And that process involves...
Well, I think the importance is that if we don't choose a topic that anaesthetists are interested in, it won't work, because we have to have buy-in.
Exactly.
We have to have buy-in from pretty much every hospital, otherwise the numbers don't work. The themes will work, but the numbers won't work. We want the numbers to be as accurate as possible. So we have to choose... So I just lost my thread of...
selecting the topics.
Okay. Yeah. So in the first instance, NAP 3 was chosen because Tony Wildsmith was particularly passionate about central reaction block and complications. That was a success, and NAP 4 was chosen almost by serendipity. There was Elaine Bromley's death and the death of Gordon Ewing, which were prominent cases, and there was a conversation between the Difficult Airway Society and the college, which meant that airway management was chosen for NAP 4. For NAP 5, 6 and 7, the topics were put out to tender, and we've had increasing about 100 people make proposals for each NAP. Those are then long-listed and short-listed, and we're in the process of doing that for NAP 7. So,
are you able to divulge what NAP 7 may be, or is that... I thought I'd try anyway.
So we're down to the last 3.
Oh, right, okay.
And I'm quite excited about whichever it was. It could be any of these 3, and I think they would all be good projects. So I think the next project will be another topic which is of interest to anaesthetists and of importance to the patients. It has to be important to the patient, otherwise we're wasting our time.
Excellent. Well, I look forward to that. So, back to the main topic, NAP 6. Can you walk us through, if you will, the project and the kind of highlights that have come about from it?
So each NAP has its own unique flavour. The flavour with NAP 6, the sort of, I guess, the new thing with it was that we were very much cooperating with. So NAP 6 studied life-threatening perioperative anaphylaxis, and there was a very significant cooperation with clinical immunologists and allergists, which was new for us. So from the planning perspective all the way through, both specialties, or all 3 specialties, were involved. And that's new. Although we collaborated quite a lot with neurologists with NAP 3, and we collaborated with psychologists in NAP 5, this was new. And we've tried to take the whole allergy process from preoperative assessment, the perioperative period, referral and investigation, and then follow-up and communication and getting back to the patient. The data collection, the analysis and our recommendations follow that whole process. So there are recommendations that are relevant to anaesthetists and relevant to allergists and clinical immunologists. Yeah. Importantly, we've always strived with our recommendations to stratify them. So we have national recommendations, institutional recommendations, and individual personal recommendations. And again, we've done that with NAP 6, so that we hope to drive change at all 3 of those levels.
And so, what were the findings? What did you maybe what were the surprises for you, and then the kind of the rest of the results?
Perhaps I'll start with the numbers. The numbers are pretty straightforward. So previously, many reports. So there are 5 grades of anaphylaxis in terms of its severity or hypersensitivity. So grade 1 and grade 2, most anaesthetists would think as minor events, with grade 3, 4 and 5 being life-threatening complications. We only looked at grade 3, 4 and 5, and 5 is fatality. And most previous studies have reckoned there are about 1 in 10 to 1 in 20,000 cases of any grade anaphylaxis. We found an instance of 1 in 10,000 for life-threatening anaphylaxis, perioperative anaphylaxis, and based on the data that we had to exclude because it wasn't complete, etc., that might be as high as 1 in 7,000. So the instance is slightly higher than previously reported. In terms of the culprits, which is what people are often interested in, most previous studies have identified neuromuscular blockers as the most prominent culprits, but antibiotics were significantly the top guns here. Yeah. So antibiotics accounted for about half of the episodes. The good news from an anaesthetic point of view and from a patient point of view is that we only looked at life-threatening complications, but 96% of patients who had a life-threatening perioperative anaphylaxis episode were successfully resuscitated. And most of those patients had a short period of time on intensive care, were out of hospital within a couple of days. And while anxiety was prominent in those patients about future anaesthetics, most patients made a full recovery. So that's a good, as the naps often are, they're often good news stories dispelling people's fears.
So the immediate care seems like it was very good. There were some concerns, am I right, in terms of the promptness of follow-up or the kind of...
Can I just talk about the immediate care first? So,
sure, yeah.
Yeah, so this was more of an audit than the previous national audit projects have been. They've really been service evaluations. But we did sort of tag or benchmark quality of care against various published guidelines for this. And immediate care, as you say, was very good. And so in most cases, there was compliance with what we expected in terms of good care, well above 90% for the 260 cases we looked at in detail. The one area which was down at about 50% was early or appropriate CPR.
Right.
And one of the controversial areas that we discussed was at what point should CPR be started when there's hypotension? Yeah. So if the patient's awake, in most circumstances, the definition of cardiac arrest is pulselessness and absence of signs of life. You start CPR. More than 90% of cases of perioperative anaphylaxis occur when the patient's unconscious and therefore will be displaying no signs of life. And about 70% of patients, so all patients had a hypotension, about 70% of patients had blood pressures below 60 or below 50. But only about less than 10% of those patients got CPR. So we took expert advice and we felt that CPR should probably be starting in those patients if the blood pressure is below 50. It's controversial.
Yeah, so they have a pulse, they have a blood pressure.
Well, they probably don't have a pulse. So if you have an arterial line in, then you're generally pulseless with a blood pressure of 50. And a non-invasive blood pressure monitor will overread in hypotension.
Right.
So if your blood pressure monitor is reading 50, you're almost certainly pulseless. And most of the cardiac arrests, so 15% of people had a cardiac arrest, and half of those were preceded by prolonged hypotension.
Because I suppose, once you get to that point in an anaphylactic shock, you're on the downward spiral.
Certainly CPR should not be done instead of fluids and adrenaline. It should be done at the same time as fluids and adrenaline. So adrenaline should be given promptly, if you're given intravenously according to current guidelines, and fluids should be given liberally, and probably not enough fluids are given. But as part of that, there should be an immediate recheck of the blood pressure, and if the blood pressure is 50 or below, we really think the CPR should be starting.
Okay.
One for discussion.
Yeah. And then, the long-term follow-up, you voiced some, not concerns, but just highlighted that there can be some improvements made in terms of referral to allergy clinics and things like that.
Yeah, it's quite a complex process, the referral, because so the average wait for somebody to be seen in an allergy clinic is about 100 days. And so the anaesthetist has to report the event that's happened, probably to the hospital, maybe to the MHRA, have to say what they think the trigger was. They're actually right 3/4 of the time. The patient then has to go off...
Is that from the information?
Interesting. Yeah. So they have to go off to the allergy clinic, be seen. That information then has to come back to the anaesthetist, identifying the correct target, the correct culprit, the actual culprit, and then that information has to ideally then be reported to the patient, to the MHRA, and obviously in that interim time, the patient needs information about what is safe for them, what the culprits are thought to be or what the culprits might be, because most patients have had their surgery cancelled, so may need their surgery while they're waiting for the allergy clinic, or may need emergency surgery in the interim. So we found about 15% of the cases involved cancellation of urgent surgery. And so giving this information, amongst the tools that we've produced from NAP6, we've produced standardised referral for allergy clinics, improved from what was before, standardised letters for patients, standardised letters from allergy clinics, to try and improve all this communication with patients, because we think that's really not where it should be.
And where can people listening now, where can they find all that, those tools to be used in everyday
currently,
practice?
if you simply Google NAP6, then you will go to the college website, or it's actually the HSRC website, and there's a resources section there which has all those outputs and many others. And
on the culprits of a lot of the anaphylaxis shocks you had, you obviously mentioned antibiotics, but there's an interesting point about ticaplanin, this one that we often go for first line if someone's got a penicillin allergy or various other allergies, but it turns out that actually it could be one of the main precipitants. Is that
so
fair to say?
Ticaplanin is in about a quarter of cases where ticaplanin is used, it's used because someone's allergic to penicillin. About 1 in 5 inpatients and 1 in 10 patients altogether claim to be allergic to penicillin, and the allergists and immunologists disagree as to whether it's 90% or 99% of those patients who actually are not allergic. When we then give ticaplanin, so we might give ticaplanin instead of cefuroxime or instead of flucloxacillin, and turns out that it's 17-fold more likely to cause life-threatening anaphylaxis than those drugs. So we're trying to avoid anaphylaxis from penicillin by giving a different drug, by giving a drug which is much. I mean, the incidence is still very low, so the incidence of anaphylaxis is still low, but there is some perversity to it. And the other thing is that these second-line drugs are more expensive, less effective, and more likely to cause antibiotic resistance. So we're giving antibiotics to 60% of patients having procedures in the UK. Don't know if they're all needed, but that's a huge number. It's another number to come out of NAP6. So if we could delabel these patients in terms of penicillin allergy, then overall that would seem to be a significant benefit to healthcare in general.
And I think that's something that all anaesthetists would recognise. The number of people that say they're penicillin allergic, they can't give any details, and in reality, we all know that they're not. But but it's in black and white, and you have to act accordingly, and that's a big problem.
It's very difficult. And one of my learnings, I have lots of learning from the anesthesiologists and clinical immunologists, but so there is a nice guideline that says that if patients are allergic to beta-lactams and another group of antibiotics, or if they're allergic to beta-lactams and are likely to need beta-lactams, they should actually be referred to an allergy clinic preoperatively to determine whether they are allergic and identify what are the safe drugs. I suspect that's not happening. So seeing the patient on the morning of the operation and finding that they have a dodgy penicillin allergy history is no good to anybody.
No.
So we need to get better in the pain clinics and probably in GP surgeries and perhaps think about this in a more global view to try and improve our antibiotic stewardship, which is a massive issue, as we know, with healthcare.
So, as you mentioned, there's lots of things that have come out of this, not just acute care of anaphylaxis, long-term follow-up, antibiotic stewardship. That's an enormous topic in itself. What are you hoping are going to be the main changes, maybe, that come out of the NAP6 project?
The main changes. A lot of the information is reassuring. We've debunked a few myths, so we should continue to prioritise giving adrenaline and liberal fluids. People were not giving enough fluids when patients have preoperative anaphylaxis. Regarding antibiotics ideally should be given to the patient when they're awake. Something like 80% of anaphylaxis will occur within 5 minutes, and if you've only given the antibiotic and nothing else, the resuscitation is simpler, the identification of the culprits is simpler, and the whole process is simpler. So that's a strong recommendation. In terms of neuromuscular blocking agents, suxamethonium has roughly twice the instance of the other agents, but the other agents are largely similar. And so you don't really need to choose your muscle relaxant on the basis of anaphylaxis, but simply on clinical indication. Again, with the muscle relaxant, Sagamodex was not shown to have any particular benefit either in treating rocuronium anaphylaxis or in treating anaphylaxis in general. I come again back to the fluids. Give more. Adrenaline, give it early. Probably cancel surgery. So 50% of patients who had, more than 50% of patients who had anaphylaxis went to ITU afterwards, and the majority had catecholamine infusions. So I think carrying on with surgery if you've got grade 3 or above anaphylaxis probably is not a wise thing to do. And we didn't make any recommendation for how soon these patients should go home, but we thought probably going home the same day was unwise, as happened in a few cases. There's a whole host of other recommendations.
Do you think this may... Do you think... on the antibiotic stewardship, do you think this may prompt further debate on our rationalization of antibiotics? I mean, there are other reasons why we shouldn't, in fact, antibiotic resistance, but now anaphylaxis being such a key part of it, maybe this will enliven the debate further.
Yeah, if I could change the panel that we had a panel of 25 very hard-working people getting NAP6 as good as we could. I wish we'd had a microbiologist on it. So a lot of the very interesting information, so there are going to be 5 papers in the BJA, 1 in clinical experimental allergy, and about the various aspects, and 2 of them about what we do as anaesthetists, our activity levels and the drugs we use. And the fact we use antibiotics for 60% of procedures, that's including every procedure. If you're doing endoscopy or epidurals for labour, those are amongst those cases we looked at. 60% of those get an antibiotic. Do we really need that? But also, when we looked at the antibiotics by specialty, so say orthopaedics or general surgery, there were up to 10 different antibiotics that were given. So for the same specialty and broadly similar operations, does it make sense that in different hospitals 10 different antibiotics are being given? I think it probably doesn't, and if it does, we need to explore that further, because the antibiotic Armageddon is a real problem. Yeah. And while NAP6 looked at anaphylaxis, I think it's highlighted some issues which perhaps require a greater exploration. The other area, if I could just mention, the other area that was interesting. So for the first time, we tried to involve the independent sector in NAP6. So there were considerable efforts to engage independent hospitals, and there were about 300 independent hospitals. So previously it had been recommended, and we'd considered trying to involve these smaller hospitals. We thought that particularly for anaphylaxis, so anaphylaxis can affect any patient having any operation, particularly if they're having antibiotics, as many patients in a private hospital will, or muscle relaxants ditto. So unpredictable. And so we tried to engage the independent hospital. Unfortunately, engagement was poor. So in contrast to the NHS, where there are 100% of hospitals engaged, the engagement was between 10 and 13%, depending on which way you measure it. And what it means is that we can't characterise what's going on in private hospitals. In some hospitals, more than half of the patients are NHS funded, and of course, whatever the funding, every patient in those hospitals matter. But it means that for perioperative anaphylaxis and for other critical events, so if you have an anaphylactic reaction in a private hospital, a small hospital, there's probably not an anaesthetic department. There may not be SOPs. There may not be another anaesthetist who can help you next door. If there is another one, he might be your competitor rather than your mate. I believe, so I'm told. The team there may be less experienced with dealing with the really sick patients. Yep. There's unlikely to be an intensive care. So 75% of patients are going to intensive care. Only 20% of private hospitals have an intensive care. They're going to need an adrenaline infusion. They may need vasopressin. They may need glucagon. So we found that more patients should be getting glucagon and vasopressin than currently getting it. And they're going to need transfer to another hospital. So there are clearly challenges for these events happening in independent hospitals. And despite our efforts, we're unable to characterise what's going on. It may be that the care is absolutely excellent in the independent sector, and that these patients who will be having these events are cared for in an exemplary fashion. But we don't know, and it's a shame in this day and age that the joined-up National Health Service and other partners are not able to provide that information in a joined-up way. So
for NAP7, hopefully there's going to be more collaboration with the private sector as well.
Well, I hope so. I think we learn from each of these projects, and we try and improve our processes. And I hope a conversation will happen such that those organisations are keener to get involved, and we improve our processes to support that engagement as well.
Tim, you advocated the best time to give the antibiotics is when the patient's awake. Anecdotally, some people will say that the best time to give an antibiotic if there's a risk of anaphylaxis is actually when they're anaesthetised, intubated, you've got no airway concerns that may develop as part of the anaphylaxis. I'm interested to know, kind of combining some of your naps here, but were there any airway issues in the cases that you examined for nap 6?
The simple answer is that there were almost none.
Really?
So of the 266 cases we looked at in detail, there was one case of front of neck airway. We weren't clear whether that was due to anaphylaxis or other reasons. There were precious few cases where patients even needed to have their airway changed to be intubated, and there were no difficulties.
Really?
So what seems to be the case, which is actually previously known, is that the more severe your anaphylaxis, the less likely you are to get rash, generalised swelling, and indeed laryngeal edema or airway swelling. So in the severe
primarily
cases,
the blood pressure, the hypotension.
Correct. So bronchospasm and hypotension are the predominant features, or cardiac arrest. And so we simply didn't see that as a problem, and therefore the idea that you must secure the airway before giving your antibiotics to protect the patient can be debunked. I would say there are 3 benefits to giving your antibiotics early. The first is that with the awake patient, you can confirm that they're not allergic to the drug they're about to give. That's a common mistake that anaesthetists do make, and others, of course, do make. The second is that if you do have anaphylaxis, you should detect it before induction of anaesthesia, and it won't be confused by post-induction hypotension and can be treated probably more easily. And a third and important issue is that the investigation is made considerably more complicated. So investigation of perioperative anaphylaxis is quite complicated because on average we're giving 8 drugs for every anaesthetic, but up to 20. And disentangling what drug has caused those problems can be very difficult. And so if we've only given 1 drug or 2 drugs, and we send the patient to the allergy clinic, their job is a lot easier, and that's in the patient's interests. So one of our key recommendations is that antibiotics are given as early as possible, and ideally to the awake patient.
Look, Tim Cook, it's been fabulous talking to you. Thanks very much for coming. This is going to be lots of debate, I'm sure, around nap 6 and all the offshoots from it. We must go, though, because one thing, lunch is up, but also the next session is starting soon. So thanks for listening. You can catch us on Facebook, Twitter and Instagram, or go to www.topmedtalk.com. Once again, thank you, Tim Cook, and thanks for listening.
TopMed Talk.
Nate Majerison here. Thanks for listening to TopMed Talk. Now, before we let you go, it's important that we remind you to subscribe to TopMed Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com, and click on the section marked email updates. Finally, TopMed Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMed Talk. That's ebpom.org/meetings.